At the outset, I'd like to thank Dr. Thomas Alexander Ajit Mulasari for asking me to speak here at the STEMI India Conference 2022. The topic for me to speak this afternoon is DAPT in the high bleeding risk patients. Do we have a consensus? At the very outset, I could say that there is a lot of literature that is available, but in the setting of STEMI, the separation is not very clear. But let me try and do over the next 12 minutes, try and deliver to you the best possible consensus that we have. What do we do to our patients with myocardial infarction and needing the dual antiplatelet therapy and who are at high bleeding risk? Now, we all know that the current standard of care in STEMI patients is that primary PCI is the preferred strategy whenever available, but it is not really available in all parts of our country, and fibrinolysis if PCI is not available. The STEMI group has over the years shown that fibrinolysis is extremely effective and has brought down mortality and also helped and deferred angioplasty, that is within the next 24 to 48 hours pre-discharge, has brought down mortality considerably in this group of patients. Now, once again, dual antiplatelet therapy or DAPT is the standard of care initially, irrespective of the treatment strategy adopted. So for patients receiving fibrinolysis, a loading dose of clopidogrel of 300 milligrams in patients 75 years or younger, followed by 75 milligrams OD of maintenance dose, or no loading dose in patients over 75 years of age is standard. For patients receiving primary PCI, either we give them ticagrelor or prasugrel, and we are all familiar with the dosages. Now, rationale for DAPT after PCI. Now, why do we give dual antiplatelet therapy after PCI? Initially, we started just giving just plain aspirin. It brought down mortality considerably, but when we started some of the trials and we showed that we could give these patients dual antiplatelet therapy to further reduce mortality. It improves morbidity and mortality by reducing ischemic events, but increases bleeding risk, especially for high-risk bleeding risk patients. The duration of DAPT after PCI with intracoronary stents, there have been various recommendations from 1 month to 3 years, depending upon the patient profile. So this slide, which was published in 2020 in the Journal of American College of Cardiology, very clearly shows us that the highest risk of bleeding is in the day 0. And as we go away from the PCI or the non-PCI patients, the fibrinolytic patients, the risk of bleeding and mortality comes down. So it's very important that we note this particular the all-cause mortality after post-discharge patients treated with or without coronary artery. So it does definitely change, whether it is with PCI or without PCI. There is a changing pattern over the year, over a period of 12 months. Now, bleeding risk with DAPT. Bleeding is most common non-cardiac adverse event among those undergoing PCI. DAPT in patients carries a major bleeding risk of about 1 to 2% annually. In the absence of high bleeding risk features, in the setting of PCI, major bleeding occurs in 1 to 2% of the patients periprocedurally and up to 4% at 1 year. So we see that this is a risk that is just not irrespective, even if they are not very high risk, there is a 1 to 2% risk during the procedure and about 4% at 1 year. So this is impossible to avoid, at least with the presently available platelet agents. So what happens to bleeding and mortality in high-risk bleeding risk in the ACS patients based on the ARC high bleeding risk definition? So the patients who do not have high bleeding risk, if you look at it very clearly, and at this, it's very easily seen. If you look at the bleeding, which is in red, and the mortality in blue, and the net difference is hardly anything. Whereas if you look at the high bleeding risk patients, you see there's a considerable amount of mortality as we go along, and it continues. And the mortality, of course, also is much less than the bleeding, but it's slowly, and if you see that the net difference, it catches up as we go away from the number of years away, from at 6 years, 8 years, and it almost merges at the end of 10 years. So this is published somewhere quite a lot in 2020, and it showed that. So what we're basically saying is that in high risk, no risk patients, the net difference is very low, but in high bleeding risk patients, there is a definite higher risk of bleeding. So what is the magnitude of the problem? What we see is that nearly 1/3 of all patients treated with PCI are at high bleeding risk. However, these patients are frequently excluded from clinical trials, so that it actually vitiates the data, because we don't want, sometimes these patients are taken away from the trials and are, they definitely still receive, but each one we do, I think that's why there's a paucity of robust data. So how do we identify these high bleeding risk patients? There are many scoring systems, definitions exist. But at current, the most commonly used definition for high bleeding risk is the one established by the Academic Research Consortium for High Bleeding Risk, ARCHBR, defined in 2019. There are 20 clinical criteria, 14 major and 6 are specified. The presence of at least one major or 2 minor criteria, risk factors, makes this patient a high bleeding risk patient. I'll just show it in the next slide, and I think most of you would have seen. So this is the ARC major and minor criteria, and you look at it very clearly. You'll find it in any book and any of the journals, and you look at it, and this was published by the European Heart Journal in 2019, as we see it, volume 40. And I think it's quite useful for each of us to have a look at it and be familiar with it, to decide which of our patients require short DAPT or long DAPT. Now, if you look at the validation of the academic ARC for high bleeding risk definition in contemporary PCI patients, you see that patients who are high bleeding risk at the end of 360 days, there's a 9.1% primary bleeding endpoint versus 3.2% in the low risk patients. So there is definitely, this criteria helps us identify the patients who would be at higher risk of bleeding. So balancing bleeding and ischemic, the risk of stent thrombosis is highest within the first 30 days after PCI. However, the risk of bleeding with DAPT remains relatively constant throughout the duration. So what we are saying is that even though the risk of stent thrombosis is highest in the first day, but DAPT remains relatively constant throughout the duration. In fact, we saw in the previous slide that it sort of keeps increasing. Thus, the benefits of DAPT are greatest during the first 30 days after interventions, whereas the risk of stent thrombosis continues to fall with time after 30 days, much smaller after 6 months. So therefore, what we're trying to say is that it may be advantageous to shorten DAPT to optimize the risk-benefit ratio in patients with a high bleeding risk. So current guide, if you have patients with DES with PCI, the one with stable ischemic heart disease and ACS, no bleeding, high bleeding risk, what do we do? So the ACC AHS says that high bleeding risk patients, you can go up to 6 months with DAPT, and it's a 2BC. And ESC says 2AB, with the level of evidence being B. Of course, I'm not going to go into the stable ischemic heart disease because we're basically there. Whereas with the no high bleeding risk patients, both the things, they say they can go up to, there's a class 1 recommendation, and it can go up to, definitely up to 12 months. The 12 to 30 months is a slightly gray or orange zone, as we can call it here. So this is how can we shorten DAPT duration safely? You look at a patient who's got balanced ischemic risk and bleeding risk, whereas somebody who's got ischemic risk, which is less than the bleeding risk, whereas both the differences, and ischemic risk is much higher than the bleeding risk. So in that case, when here we might have to go on to a later If the ischemic risk is very high, the DAPT will have to be increased, and we'll have to individualize the patient, each patient, rather than. So this slide very nicely demonstrates what happens with each of our patients when we look at it. What is the difference? So what is the evidence to support shorter duration DAPT? No randomized involving STEMI patients. Data mostly for elective PCI and non-ST ACS. Extrapolation of the conclusions to STEMI may be appropriate. So this is that's the evidence that we have. So the number of trials that we see which have been published over the last couple of years, they're mostly non-inferiority trials, and the objective is, some of them are NACE, some are target lesion failure. So they're broadly in two groups: discontinuation to the P2Y12 discontinuation, aspirin discontinuation. So we have some superiority trials and non-inferiority and inferiority trials. And what do they show? That's in high-risk patients. Studies finding support short DAPT. Every one of them you see supports a short DAPT. Only the global one, Deatharamide, did not support shorter DAPT. Okay, so this is one more important slide which we have shown. Studies recently completed show evaluating short DAPT in high-risk bleeding patients undergoing PCI. If you see, there was some very important thing which included the biofreedom polymer-free DCS, which has been, all these trials have been completed, and they have shown that even with the shorter duration DAPT, that these patients do as well as the patients with long-term DAPT with much less bleeding risks. So if you look at all these trials, they are very, very important for us to note that these patients, that short-term DAPT can be used in patients who have got high bleeding risk. So the Twilight trial, which showed ticagrelor plus aspirin, ticagrelor plus placebo, and you see that what happens is that the mortality is similar with placebo and ticagrelor. So again, even at 12 months, so we can have a single antiplatelet agent. That's very, very important to note. Whereas ticagrelor plus bleeding with ticagrelor with aspirin, ticagrelor with placebo, you see that with aspirin, the bleeding is much, much higher at 12 months. So that's why it's very important we note here that the patients, there is a much higher chance of bleeding when you have dual antiplatelet therapy. So we can have a shorter DAPT. So stop DAPT, 1 month dual antiplatelet followed by clopidogrel monotherapy, the ACS. So we see that the population was 4,100 patients, 1 month DAPT, 11 months clopidogrel alone. Control was with 12 months DAPT. And you see that at primary 1 year, 5-year follow-up is planned. This particular study is conducted exclusively in Japan. So the conclusion: 1 month dual active followed by stent implant is high-risk bleeding, preserves ischemic benefits and reduces the bleeding risk. That is what is the conclusion of this master DAPT trial, which is presented at the ESC Congress. So as we have said that we can put these patients into 4 basic groups: increase in bleeding risk, increase in ischemic risk, and overall risk adverse benefit ratio. So in conclusion, DAPT administration in patients with high bleeding risk remains a challenge, tightrope walk. Not enough data is available currently to make uniform recommendations regarding the duration of DAPT. Multiple factors which influence ischemic and bleeding risk should be analyzed carefully and treatment duration individualized. Thank you very much for your patient hearing.